Okay. So let's start with a recap from yesterday's session.
Mm-hmm.
Okay. So if you have a sudden sudden loss of muscle tone, then you would rather take venlafaxine. That will help with your cataplexy. And if you hear voices before you sleep, then I'd rather do sleep study for you because you could have a narcolepsy. Okay, so that's the thing. Um, so what if you have anemia with hyperbilirubinemia? What do you think is going on with negative Coombs?
Then that is either you said it could be either like AVO incompatibility or it could be G6PD.
Yeah, but since negative Coombs test, then it's G6PD. But if I tell you
Okay.
Coombs test positive, it's ABO incompatibility.
Okay.
Okay, so it's rather, even if you forget the pathophysiology and everything, just focus on the clue, the keys on the question. They describe, they tell you the surrounding informations, and you gotta know the center. What is the real information? Because Coombs test is the antibody response to that. So this is autoimmune hemolytic anemia from its name. So you
I'm sorry,
gotta,
say that again. Coombs test what?
yeah, Coombs test is detect the antibodies that attacking RBC.
Okay.
So it's present when autoimmune hemolytic anemia. So if it's
Okay.
autoimmune, it will be positive. But if it's not, like in G6PD, it will be negative. G6PD is just enzyme deficiency.
Okay.
That's about it. So biliary atresia, breast milk jaundice, physiologic jaundice, all of them don't have anemia. So by just finding hemoglobin decrease, you just exclude them out. So that's a question for this. So if you have diverticulitis and you didn't improve in 3 days, then I would rather do CT because it could be an abscess. That's the thing. Okay. If you are an elderly having agitation, I'll give you low dose haloperidol. So this, so what are the criteria to give osteobisphosphonates?
So to give bisphosphonates and osteoporosis, you have to have FRAX percentage more than 20. And yeah, your Z score should be, no, not the Z score. But there should be history of maybe bone fracture and age counts, right? No, Z score should be like minus 2.5.
Yeah, excellent. Yeah, and 10-year probability for major osteoporotic fracture more than 20 years is the FRAX, or hip fracture more than 3% based on the
Okay.
FRAX calculator.
Okay.
So this, if any of that, then you do that. Okay, so when you have a thick protruding rectal mucosa with bluish discoloration, then I'd rather give you surgical consultation. But if it's mildly protruding, then I'll manage it medically. That's the thing. Okay. When you have a weight loss and increased AP diameter, then most likely it's pulmonary cachexia syndrome. When you have absent rugae in the fundus of the stomach, then you most likely have pernicious anemia. And you will have positive autoantibodies against intrinsic factor, not vitamin B12. So that's the thing. Okay. When you have restricted movement of the hip and with increased leukocyte, then most likely septic arthritis. Okay. That's another thing. So when you have adenoma, polyp with adenoma that's been taken out, then I would rather do a colonoscopic surveillance every 2 to 3 months.
So it has to be a villus adenoma or any type.
Yeah,
Doesn't matter.
only if it's adenoma,
Okay.
adenocarcinoma. Okay. If it's sessile polyp, then I'll do every 2 to 6 months. But if
Oh,
it's
okay.
adenocarcinoma, every 2 to 3 months. So that's
2 to 3 years, you said, or 2 to 3 months?
months.
2 to 3
Yeah,
months.
so he gotta have a tube in his butt every 2 to 3 months.
And sessile polyp, you said 3 to 6 months.
Yeah, 2 to 6 months, yeah. And how about if it's hyperplastic?
Oh, it's benign.
Yeah, every 10 years. How about if it's less than 1 cm, tubular adenoma?
Same thing. It's benign, right?
This one every 5 years.
Okay.
How about if it's more than 1 cm, tubular adenoma?
Then every year or every 3 years?
Every 3 years, yeah. Okay, that's okay. Okay, yeah. Okay, so I like those types of cases, you know, it's very easy to spot. Like when you are a 6-year-old girl and who just came from Hayati like a couple of months ago, 3 months ago, or whatever, and you found distended abdomen, hyperactive bowel sounds, generalized tenderness, fecal alcohol to blood test positive, and eosinophil 15%. Okay, everything else is normal. So what do you think is going on here?
Parasitic helminth infection.
Yeah, so now look up. The question is so easy. Look at the answer. That's what they gave you, the answer choices. What to
So
pick.
stool test for ovine parasites.
Yeah, right? So you see, it's very, very easy. Like, it just gave you all the clues on it. So why not the other ones? You want to comment on the other one?
So interferon gamma, we would use that for TB, but I forget if it determines the latent or chronic infection.
Latent,
That's
for latent.
for latent. Serum folate, somebody who would be deficient in folate or B12, and then you have to explore that. IgA antitransglutaminase antibody. Is that for celiac? Not too sure. And stool culture, everybody gets a stool culture, right? Who's having diarrhea or some infection like that.
Yeah, so these first three is easy to exclude, you know. So there are, most of the time there are options very easy to exclude, and then you get confused with two. Okay, so this interferon gamma for latent TB, folate when you have anemia, and macrocytic anemia. Look at that. They gave MCV and it was normal, so it's unlikely. Okay, the folate anti-tissue transglutaminase is for celiac disease, and you know how celiac present: weight loss, anemia. And they have the MCV decreased, okay, but they don't have eosinophilia. Stool open pressure is the right answer. Stool, so those are the two things that's kind of a little bit tricky, not much. So stool culture, we do it when the presentation is acute.
Okay.
So this patient, she's having her symptoms for the past 3 months. She had decreased appetite, loss of weight, and diarrhea, abdominal pain. But this bacterial stool culture is for bacteria, right? Bacterial causes of diarrhea, like E. coli, Salmonella, Shigella, Yersinia, Campylobacter. Okay, and these things, what do you think is quick or long?
Quick overview stool culture.
Yeah. Like this bacterial enterocolitis is very fast in onset. Like it's 5 days, like 5 days onwards. Doesn't last for too long. But these parasite like just sits there and keeps annoying the kid. Come on, just leave him alone. Like why would you? But they're just there causing like this abdominal pain. So what parasite? What that caused this?
Could be any one of them, Enterobius or Ascaris.
Yeah, and like hookworm, those hookworm, intestinal nematode, that's what they call. Like ankylostoma, duodenal, or Necator americanus. That's the. So they, you know, they put their eggs into this intestine, so it goes out with the stool. Okay, that's why. So initially, so some of them cause GI symptoms. Okay. And and then goes to the bloodstream and causes lung symptoms.
Okay.
Like it causes non-productive cough sometimes. Okay, so that's and then and so this when you have cough with diarrhea, abdominal pain, that's over a long period of time. then with eosinophilia, then you suspect parasitic infection most likely.
Okay.
Okay. So this tool ova and parasite is very sensitive. Okay. So what do you give him? What is management?
Albendazole.
Yeah. Or nitazoxanide too. That's another one. Antihelmintic, antiparasitic. Okay. Period.
The question before you read it.
Yeah. This one is a very easy, straightforward question. Like clozapine, what do? You just blood test to monitor the neutrophil count. Kidney function test is for what?
Thyroid and kidney, that's for lithium, right?
How about C?
Periodic clozapine plasma levels. I mean, you do it, but you don't do it that often.
Yeah, exactly. Not that often. How about B?
Dietitian also prevent hypertensive crisis, maybe with SSRIs,
Yeah,
like
like
inhibitors.
mono.
Yeah, the
Mono
monoxide.
amino oxidase inhibitors. And they don't prescribe it. This one is very dangerous medication. How about this one?
For Depakote.
Yeah.
VPA.
Yeah, excellent.
Folic acid.
Yeah. So that's about it. It's a very easy question. That's gonna make sense.
Okay.
So that's why like this periodic plasma clozapine, this used for other drugs, not the clozapine, like lithium, valproate, norsertanib. Clozapine, once you reach target, I think.
How often do we do it for valproic and lithium?
Okay, so this is a good thought, like closing patent foramen ovary. However, so patent foramen ovary, it's present in 30% of the population. It's asymptomatic. You and I, we could have patent foramen ovary. It doesn't cause any problem. It's just there. Like so it doesn't cause any problem. And with this one, the way of stroke that it causes embolic stroke. Like you have a DVT, they tell you signs of DVT, like swollen leg.
Okay.
He's been bedridden. That's how it's called, embolic type of DVT.
Okay.
Like so DVT goes to the patent foramen ovale and then goes where? To the stroke. So this is a very tricky question they always ask about. So DVT usually should cause the lung issue, right? PE, right?
Right.
But only in these people, patent foramen ovale can go to the brain and cause stroke.
Okay.
This is only in 30% of population.
Okay.
They have that. So this patient presented with slurred speech and stenosis.
Right.
Okay, so this high grade 70 to 99 is very high grade stenosis. So the best thing is that we do endarterectomy because it's symptomatic. So why not the other ones? You want to comment on the other ones?
Yeah. So you're saying that leave the foramen ovale alone because it's most of the time asymptomatic, and if it does present, it's like a DVT or something.
Yeah.
But you said go to the brain too.
Hmm?
But you said it could go to the brain too, or no?
Yeah, so usually, if I don't have a patent foramen ovale, the DVT will go to the lung.
Right.
Right? Because there's no way it can go to the left heart. There's no ovale. So DVT, we're worried that causes the pulmonary embolism. But in those types of patients, which is 30% of the population, DVT can go through the patent foramen ovale and goes to the brain and cause a stroke. Okay, so this can happen only if I had a patent foramen ovale. And the question stemmed if they wanted you to target that, then they will tell you there's a DVT.
Ah, okay. All right. So then additional clopidogrel in strokes, you don't really give clopidogrel. It's harmful. So that's why I think it's not choice A. Carotid endarterectomy, I mean, with 75%, yes, it's like you said, 70 to 99% we have to do it. Extended ambulatory, I mean, that's a Holter. What's Holter going to tell us any much more? We already know. And oral anticoagulation, not too sure. But the confusion was with the closure of the patent foramina valley, which you said we don't need to do it, just ignore it. That's what I think.
Yeah, exactly. So the clopidogrel, it's used with aspirin after we do the endarterectomy. So this is the thing. Clopidogrel is important for stroke, especially if he was already taking aspirin, then we add that. But if he's not taking aspirin, then we just give him aspirin. Okay. Rhythm, EKG rhythm. This one, if patient we suspect cardiac, like atrial fibrillation as a cause of a stroke, which obviously they tell you the stenosis is 0 or 20%, then you may do that to see if it's an atrial fibrillation or arrhythmia. Okay, because this arrhythmia causes stasis and increased risk of emboli. Okay, why not anticoagulation?
I don't know. Why not?
This one used for atrial fibrillation, left ventricular thrombus, not for stenosis.
Okay.
Okay, yeah, so that's about it.
I'm sorry, repeat that again. Why not anticoagulation?
This one, we use it in atrial fibrillation, warfarin.
Okay.
This patient.
Not strokes.
Yeah, he has mild left atrial enlargement. Yeah, that's about it. Let me see if they said in the EKG. Yeah, and the EKG was normal. Yeah. So the EKG shows normal sinus rhythm. So it's unlikely to be this case. Okay.
Okay.
That's the thing. And another thing about patent foramen ovale, we close it only if it's problematic, number one, and second thing, the patient should be less than 60 years old. But if it's more than 70 years old, like, I mean, it's very dangerous to go inside the heart, close stuff. Yeah. I wouldn't want to, like, if I had it, like, it's okay, just leave it alone.
Okay.
Unless it's causing a problem, huh?
Okay.
Very, like, it's, the goes inside the heart, like, it's, imagine, like, you just cut your chest open. Yeah. Okay. Yeah. So when you have restlessness and when you appear nervous and shakes your right leg and gets up and paces around the room after antipsychotic, then you're most likely having akathisia. So I'd rather give you propranolol or benzotropine or benzodiazepine can be used too. Okay. Haloperidol worsen his situation here. Okay. Decreasing the dose of valproate may return the manic symptoms. He's having manic, and even it's not related. This akathisia is not related to valproic acid. It's innocent, valproic innocent from this. Discontinue risperidone and start lorazepam. Yeah, so lorazepam can be used, but I don't agree with discontinuing risperidone.
Right.
That's why we gave him to begin with. Why did we give it to him to begin with? And increase the dose of risperidone. Come on, he's already having it because of risperidone. Okay, this is gonna worsen his condition. Okay, period. So that's too much. Yeah, excellent. You see, so you're going through very high level, in the exam, it's even easier than this question. I got a lot of information and you get the answer, so excellent. So in the exam, they will tell you there's a pruritus, fatigue, they may have had arthritis, right upper quadrant pain, okay? But that's excellent. You figured it out from just xanthelasma and alkaline phosphatase and hepatitis B positive, yeah. So this one, primary biliary cholangitis. So that we do anti-mitochondrial antibody. That's the thing. Okay. Yeah, so good job. You figured it out from just a few information. So that's when you'll be able to figure the question from a few information. You'll move faster in the exam, and you will pay attention to the hard questions more. So some questions you need to read every single word in it. Some questions you only need to read 2 words in it and you solve. So that's when you focus your efforts during the exam on the hard questions, you will tend to get a better score. So that's a certain exam taking skills. That's what we're working on. So excellent. We do. So when you are a 40A female with pruritus, increased alkaline phosphatase, and hepatitis B positive, then most likely you have primary biliary cholangitis. Especially if your alkaline phosphatase 600, then I will give you an antimitochondrial antibody. And if the antimitochondrial antibody is negative, then I'll do liver biopsy. And how do I treat this patient?
You can give them ursodeoxycholic acid.
What if it didn't work?
Liver transplant.
Yeah, excellent. We start with liver with the ursodeoxycholic acid, and then if it didn't work, we give liver transplant. Okay. Alpha-1 antitrypsin. They have, what do they have? They have an increased AP diameter and hepatomegaly. No xanthelasma or all of that crap. So anti-smooth muscle antibody, like I would choose that when you are a female who's taking OCP and having hepatomegaly and you have a normal alkaline phosphatase. Which is autoimmune hepatitis, that's what I'm referring to. Ceruloplasmin, when you're a 35-year-old guy with hepatomegaly and psychosis or depression or anchoria movement disorder, then I would do that. Ferritin or transferrin. This one when you are a 40-year-old guy with erectile dysfunction and hepatomegaly. I would pick this one. And you may have also cardiomyopathy, diabetes, erythropathy, so this is also associated with hemochromatosis. While this patient doesn't have any of that. Okay? And it's most likely Northern European heritage. For some reason. And sometimes associated with other autoimmune disease like Crest syndrome, type 1 diabetes. And so that's why we do antimitochondrial antibody, because it's very sensitive test. 95%. It's not like the other crap antibodies that's positive in everywhere. Like antibody. This one is pretty specific, so that's why it's a legit test. Okay. Period. Yeah, good job. So this one is a ursodeoxycholic acid. It's it's the best one for this condition. The steroid is for autoimmune hepatitis.
Okay.
Azathioprine is for, and methotrexate dose is for rheumatoid arthritis, which is autoimmune arthritis. Okay. So this primary biliary cholangitis, even if it's autoimmune but doesn't respond to methotrexate for some reason, I don't know what it is. Phlebotomy is for hemochromatosis. Okay. So the best thing here, ursodeoxycholic, it will slow the progression, and liver transplantation, it will slow all of that. Okay, so just remember steroid for autoimmune hepatitis. Okay, and ursodeoxycholic for primary biliary cholangitis. Period. Yeah, so when you have this pruritus and increased antimitochondrial antibody, then you will have decreased vitamin, like fat-soluble vitamin. One of them is the vitamin D. So what's going to happen to the calcium and phosphate in vitamin D? Deficiency.
If it's vitamin D deficiency, then both calcium and phosphate would decrease.
Yeah, exactly. So both of them. So that's why, what do we give him? We give him calcium, we give him phosphate, that's these types of patients, and then we give him bisphosphonate if there's the T-score, if there is the bone, there's osteoporosis on DEXA scan. So that's the thing. So angular chelosis and stomatitis can be to riboflavin, vitamin B12, B2, sorry. B2 deficiency. And excellent, this one, there is cardiomyopathy, is that, and Wernicke-Korsakoff, neurocognitive impairment. So both of these to one single vitamin, B1 deficiency.
B1, which is
Yeah,
fine, right?
yeah, thiamine. Which they have also oculomotor dysfunction, encephalopathy, amnesia, that's the difference, ataxia, and photosensitive dermatitis. What vitamin? What do you think?
Thiamine too?
Yeah, so this one is for pellagra, niacin, B3. They have photosensitive dermatitis, diarrhea, dementia, 3D. And then they added another D, Sigala, 4D. Photodermatitis, diarrhea, dementia, death. That's
Okay.
another D. Not a good D at all.
Yes.
So these vitamins are present when you have anorexia, alcoholism, or celiac, or short gut syndrome after surgery. Okay, so that's the sort of complication. But the one, primary biliary cholangitis, is present with vitamin D deficiency and causes this bone loss. Okay, period. Yeah, okay, so this patient, she's a 39-year-old female who had a vaginal delivery and she had a lot of bleeding. So when you have postpartum hemorrhage, like the first treatment you do bimanual uterine massage and oxytocin, and then you give her IV fluid and oxygen, and then you give her uterotonic medication. If that didn't work, you give her methylargonavine, carboprost, misoprostol. If that didn't work, you give intrauterine balloon tamponade, like this one, this option.
Okay.
If that didn't work, then you do uterine artery embolization. If that didn't work, then you do hysterectomy. There's no other option. Yeah, so that's the thing. Yeah. How do you define it? It's more than 500 ml for vaginal delivery, more than 1000 for C-section, are most likely for prolonged labor, chorioamnionitis, just multiple gestation, polyhydramnion, grand multiparity, operative delivery. Those are risk factors for it. And some causes of BPH is that uterine atony, most common, or retained placenta, like this one, which is accreta, or genital tract laceration can cause that too. Uterine rupture, coagulopathy can cause that too. So those are the causes for postpartum hemorrhage. Okay, so this one, so first thing we do uterine massage and Mr. Oxytocin. That's the thing. If that didn't work, then we give balloon. So balloon, you put it inside, and will stop the bleeding. Okay, this one after the first and second line loss failed, like methylargonavine and oxytocin. If both of them failed, then we do that.
Which one can you do after?
After we give oxytocin and misoprostol. If both of them failed,
okay,
then we give that.
Then we do the tamponade if misoprostol failed too.
Yeah. If that failed, the balloon, then we give embolization. Okay. It's mostly for someone who's had persistent bleeding and didn't respond to the first and second line treatment too. Okay. So what they do, this is a temporizing treatment, like it doesn't help much. So they do embolization, they block the artery, and then they take the uterus out. So it's not a definitive management. This is just temporary till they take the uterus out.
That would be hysterectomy.
Yeah.
Oh, scary. Okay.
Yeah. So this patient, they said soft enlarged uterus, you know. When there is enlarged uterus, then it's unlikely to be laceration. They tell you in the physical exam laceration, they tell you there is a tear or something like that. Okay, but this physical examination most likely to be uterine atony. How about retained placenta? What is that?
Retained placental. That could be the thing too, or maybe abortion.
So this, so that's the trick. How they tell you in the exam, you know. If they tell you on the physical, when the placenta expelled completely, then this means that they're ruling out this question. Okay. So let me show intact placenta on inspection. That's what they did. Placenta delivered spontaneously and intact on inspection. So this one.
Wait, where does it say placenta is intact? It says it here.
No, it doesn't say. I'm adding it here.
Okay.
You don't choose that when they say placenta is intact on inspection. Okay, so this one is added to the question then. Is delivered and intact. Okay, so that's why how you rule this question. It's just a tough question, like, but it's interesting at the same time. Has a lot of things at the same time.
Yeah.
Okay.
Okay.
So what are the risk factors? So the risk factors for BPH, what are they?
BPH?
Yeah, postpartum hemorrhage.
Oh, I
BPH.
thought you said B. Okay, never mind. The ones that you mentioned, right?
Yeah.
So polyhydramnios multiparity or chorioamnionitis, retained placenta, uterine rupture, coagulopathy. Anything I missed? I think I missed a few.
Yeah, prolonged labor, multiple gestation, polyhydramnios. So anything that pressure the uterus, like polyhydramnios, grand multiparity, operative delivery, retained placenta, genital laceration, uterine rupture, or coagulopathy on bleeding or something. So what are complications of primary biliary cholangitis?
Bone loss, progressive.
How do you
And
manage akathisia?
you give them propranolol first line or benzos, yeah, or cogentin or something.
Okay, slurred speech on carotid atherosclerosis. What's next step?
So depending on the percentage, we would do carotid endarterectomy.
Cough with diarrhea and eosinophilia. What's your diagnosis?
Parasitic infection.
Parasitic infection. Okay. So let's go to the next. Okay. So this patient, she had a postpartum hemorrhage, bleeding, placenta delivered and intact on inspection. Physical examination is normal, and the uterus is soft, palpated 3 cm above the umbilical. So this one is most likely due to uterine atony and postpartum hemorrhage. So whenever you see postpartum hemorrhage, we start with the first line, which is uterine massage and oxytocin. If that didn't work, we do misoprostol. Okay. If that didn't work, then we do Bannon for tamponade.
Okay.
If that didn't work, then we do uterine artery embolization till we do the hysterectomy afterward.
Okay.
Vaginal inspection for laceration. This is unlikely because the uterus is dilated, so it's boggy uterus, most likely atony. So we got to start with management immediately.
How would the laceration or cervical or vaginal laceration be? Would it be more blood loss or how?
No,
What would
they would tell you like there is a tear or laceration on the vaginal examination, or they tell you the uterus is normal on exam, then you would expect for a cervical laceration. Okay. Examine for retained placenta. You don't do that when the placenta is delivered and intact on inspection. Okay, so that's the key of this question. Okay. Yeah, excellent. This patient, 5-year-old boy, when they say vesicle on the posterior soft palate, that's the main thing. That's it. And he's having fever, but the fever is not specific, but that's more specific.
Okay.
Alright, so after stomatitis is the anterior oral mucosa, like in the lips, cheeks, mouth floor, ventrum of the tongue. They call it canker sore, another thing. And they don't have fever or systemic symptoms. That's the thing. So it is herpingine in the posterior. Another important differential is the herpes. Herpes is also anterior. Herpes is vesicle and ulcer on the anterior oral mucosa and around the mouth. That's the only difference. This one anterior and the herpingina posterior. Okay. The group A strep, you will have tonsillar exudate, fever, cervical lymphadenopathy. This patient didn't have cervical lymphadenopathy. Okay. Infectious mononucleus, you have tonsillar exudate too. And fever and diffuse cervical lymphadenopathy. And you may or may not have hepatosplenomegaly. So that's the thing on this question. Okay. Yeah, excellent. So anyone who present with an atrial fibrillation, the first thing you ask yourself about is the CHAD-VASc. Okay, CHAD, which stands for CHF, hypertension, age more than 75. This you give it 2. Diabetes 1. Previous stroke, that's a 2. If there is vascular lesion, like or prior MI, peripheral artery disease, or aortic plaque, this is 1. Age between 65 to 74.
Okay.
You give it 1. So there are 2 ages, so you only choose 1. This one, if it's age more than 75, you give 2. If it's less than 75, you give 1. Sex category, you give 1. Okay. Chad Vas. Let me remember. Chad's Vas. Yeah. So this you ask yourself these questions. If he had any of these, which is like obviously stroke, diabetes, hypertension, CHF, if he had any of these, then we do anticoagulation. If it's a Chad, if it's 0, then no treatment. If it's 1, we either no treatment or we give oral anticoagulation. But if it's more than 2, then we give oral anticoagulation. Like what?
Warfarin and rivaroxaban.
Yeah, warfarin. I don't know, your voice sound distant.
Oh, is this better?
Yeah.
I'm sorry, I had the computer what?
Oh, no.
So anticoagulation, we give warfarin and rivaroxaban and stuff, or just?
Yeah, we give heparin and then we continue with warfarin.
Okay.
Okay. So why not amiodarone?
It's long-term control, right?
So that's the trick. So you see, that's the trick. When they tell you this, that's a big clue. I love this sentence. So he's given oral metoprolol and report improvement after like whatever hours, 2 hours.
Okay.
Let's say 3 hours, doesn't matter. Repeat EKG shows normal sinus rhythm. So that means he's normalized with metoprolol. If I say after that EKG repeat abnormal sinus, if I just add AB, then you choose amiodarone. But if I remove the AB, it's normal then. So if it didn't control on metoprolol, then I would do amiodarone. Okay. How about digoxin? Why not digoxin?
Why not digoxin? I don't know. Well, because he's being rate controlled or rhythm controlled by metoprolol, right? So maybe that's why. Not sure.
So this digoxin, we give it when you have atrial fibrillation with a heart failure. Beta blocker is contraindicated in heart failure. So we give in patients with atrial fibrillation with rapid ventricular rate, and especially those with low or borderline blood pressure or heart failure due to left ventricular systolic dysfunction. Okay? So we use it as a adjunct to someone who have a rapid ventricular response. Then we add digoxin in addition to beta blocker and calcium channel blocker. Why? Because digoxin is a very interesting mechanism. Like it's inhibit the vagal stimulation and increases the contraction. So it suppresses the rate and increases the contractility. So it's a very cool drug. I like how it works. to work on the AT pace and increase contraction and decrease. Like if your heartbeat is 120, it's gonna decrease it to 70 and improve the contraction. So effective and efficient.
Okay.
Why not diltiazem?
Well, he's already on metoprolol, so you don't need to give another rate control.
Exactly, so he's already on metoprolol. If he can't tolerate metoprolol or something like that, then we give diltiazem. Okay. So that's about it. Let's recap this patient.
Can you tell me again amiodarone? Why not amiodarone?
So we give amiodarone if he's still uncontrolled after metoprolol.
Okay.
So if metoprolol failed, then we give amiodarone.
Okay.
But this one, after giving him metoprolol, he has normal. He used to be abnormal sinus rhythm, but after giving metoprolol, now normal. So metoprolol succeeded. So there is no need for. And the ventricular rate 77. So if I increase ventricular rate high, then I may add digoxin.
Sure. Okay.
So that's the idea of this question. And the main difference between herpangina and herpes is that herpes anterior, herpangina posterior. So that's about it. Okay, that's the end of our session. Do you have any questions?
No, I think we covered pretty good.
Cool.